Good morning, everyone. This is going to be my senior lecture for today. Um, just want to give a special thanks to Dr. Aganor, Dr. Dada for reviewing the slides, giving some recommendations. Before we start, let's just scan this QR code. It's like a small poll that we're going to be using in the first few slides. So it's like a live poll. So just scan the QR code. I guess the QR code would also appear later on, but scan it for now. Okay, so we're gonna start off with a little scene from my new favorite TV show, The Pit. Actually, I was only here for like the last part of Miguel's thing, but they had like an episode about an MCI, which is pretty cool to see how it works. All right, so let's start. Short clip.
Hi, I'm Dr. McKay. Piper, Laura.
All right, so pretend you're a doctor walking into a patient room in the ED for a chief complaint of abdominal pain and burning urination. Any initial impressions just from this quick intro? Put in the Slido poll. Or like, how about what do you think? Like, you think just a regular interaction? All right. Weird. UTI, big UTI, minor guardian women, human trafficking, maybe suspicious, non-acute distress, normal, stable, odd. Okay. Discharge. Business cash. Okay, yes. Um, all right. How about this? What if you're walking into a waiting room and you call a patient with a chief complaint of abdominal pain and burning urination and you walk to this into this. What are your initial impressions now? Yeah, right. Super super sus. Seemed like a nice guy. Red flag. Concerned about pimp. Yes. Maybe abusive partner. Okay, maybe DV, maybe trafficking. All right. Giant sus. Sus is the main. Okay. So yeah, I mean, everyone's getting red flags raised from the second picture. But what if I told you that both patients may actually be victims of human trafficking? All right. So before we go any further, just a disclaimer. Today's senior lecture is going to be on the emotionally heavier topic of human trafficking. I mainly want to speak on this topic because I believe that we may not have enough experience working with victims of human trafficking during residency. And I just want to like go back to this saying, if it's not in the differential, it won't be in the diagnosis. So I just wanted to talk about it so that we're more aware, maybe some recency effect to help keep it fresh in our mind. And I remember when I had my first interaction with a patient who was a DV, who was a victim of human trafficking in second year. Like she outright told the team that she was being trafficked, needed help. And I remember I was like so unprepared for the interaction. By the time the interaction was over, like with hospital police, with the attending, like and other staff, I felt like emotionally drained, and I also felt that I had done the patient a disservice by not being of much help. So yes, this topic is more social than medical, but ultimately, the EDs that we work in are generally considered safety nets of healthcare. So not only do we have the responsibility, but we also have the power to make a difference in the lives of these subset of patients by being more informed about this topic. So let's start off with the definition. What is human trafficking? So according to the U.S. Department of Justice, human trafficking is the recruitment, harboring, transportation, provision, or obtaining of a person for one of three purposes. One, labor or services through the use of force, fraud, or coercion for the purpose of subjection to involuntary servitude, peonage, debt bondage, or slavery. Peonage is another word for debt bondage. Two is commercial sex act through the use of force, fraud, or coercion. And three is any commercial sex act if the person is younger than 18 years, regardless of whether any form of coercion is involved. So basically, they're saying there's two types of human trafficking. One is sex trafficking, one is labor trafficking. And it was pretty interesting because in 2022, the United Nations Office of Drugs and Crime Global Report in Trafficking Persons reported that there was actually 18,917 victims assisted by the DOJ and the HHS, the Health and Human Services, in the USA in 2022. And I'm sure this is probably even just an underestimation. This is just the number of cases and victims that were um, assisted by these organizations. And of these 18,917 victims, 62% were involved in sex trafficking. A large, like 29% were also involved in labor trafficking, and 9% were involved in both. And also 78% were female, 20% were male, and 2% were transgender. And of these victims, 70% were adults and 30% are children. So these are pretty astonishing stats, right? But what I found more astonishing was that most victims of human trafficking were not foreign nationals, but actually US citizens. So normally in like social media or like movies, you would think of like immigrants being trafficked or people being kidnapped and being trafficked, but actually most of them are from the US. It could be like domestic trafficking and all that. So now you might be sitting here wondering, well, what can I do about it? Like, how can I help take down these organized crime syndicate-led operations myself? The good news is you can do something about it, and you don't have to do it alone. It takes a whole village to tackle these complex operations, and key players include not only doctors, but also like nursing, social work, case management, CPS, um, the DA, lawyers, different types of counselors, including like financial counselors, um, the law enforcement, public support groups, and even local and national organizations. And what was interesting is like a cohort of some US sex trafficking survivors in a study showed that 63% stated that they had interfaced with the emergency department during their time of exploitation. 63.3%. So in case a victim of human trafficking does show up in your ED, it is our role as a first line safety net hospital provider to identify these patients and help guide them to proper resources to ultimately help them out of their situation. So together we can make a difference. All right, so today I'm going to break down the approach to supporting a victim of human trafficking in the ER. So the first step is to identify. That's the most important step. Second step is to establish a safe space. Third step is to examine and treat the patient. Fourth step is to provide resources. And the last step, which is actually pretty rare, but is rescuing. Okay. So again, the first step is the most important to identify. So um, some some victims themselves may not identify themselves as victims of trafficking out of fear of retaliation from their trafficker, or they just might not realize that they're victims because they were manipulated by the traffickers themselves. But again, there will be red flags. And like as we saw earlier, it's really hard to um, stereotype or like identify a specific demographic who's being trafficked. Like anyone can be trafficked. Okay, but some red flags include um, if a patient has someone who speaks for them or acts as their translator or appears controlling. Okay, um, or if they're or if they appear afraid of their companion. Like it's important to consider that sometimes um, when you see a patient, they may be actually accompanied by their trafficker by bedside. So be wary of any friend or family member by bedside who may like appear very controlling, speaking for the patient, and also notice if the patient like constantly looks to their friend or family member for approval when answering questions, or if they just seem very t cautious around them. Uh, does the patient appear overly submissive, anxious, avoids eye contact, provide inconsistent history? So the way traffickers exhibit control over the victims is multifactorial and can include like physical, sexual, and emotional violence, manipulation, and this could be done through threats to the victim and the victim's loved ones too. Victims often may be subjected to like beatings, burns, tattooing, or branding for identification, forced drug use, shame, humiliation. And as you can imagine, this can take a toll on a patient both physically and mentally, which may manifest as some of these red flags. And also, a victim may not always want to disclose their status of being like a human trafficking victim for fear of retaliation from the traffickers. So they might provide inconsistent history for their medical problems and physical exams. Like, where do you get that bruise? I just bumped into something instead of admitting what actually happened. And it's also suspicious if a patient may give like false demographic information, has no ID, has few possessions, um, if they don't know the current location they're in, if they claim to be just visiting or recently arrived from another country. So, like most of the time, traffickers will confiscate all forms of identification from the victim, including passports, to prevent them from fleeing. Sometimes the victim may be undocumented. Sometimes they might not want to use their real demographic information out of fear that the trafficker will use their information to gain access to their EMR. And additionally, um, a lot of traffickers may even move their victims across like state or country lines um, to try to like subvert or like try to avoid local law enforcement. So victims are often or may be disoriented or not speak the local language, making it difficult for them to ask for help. And finally, some other red flags are if patients have signs of physical abuse, malnourishment, dental problems, branding, substance abuse, untreated chronic conditions, untreated STIs, recurrent STIs, and undesired pregnancies. So traffickers may not care about upholding and maintaining the health of their victims, and they may sometimes only allow them to visit the ER or a clinic when their health has deteriorated to the point where they can no longer function properly. So patients may come in with untreated chronic conditions like hyperglycemia, hyperthyroidism, uncontrolled hypertension, really poor dentition, uh, or like you see over there, untreated STIs, recurrent STIs, and undesired pregnancies. And again, emphasis that again, injuries and bruising inconsistent histories, sometimes branding with tattoos, especially like the ones you see on the screen with like names, barcodes, currency, chains, should raise alarms in your head. But as underlined on the bottom, the more common identifying factors tend to be patients with untreated chronic conditions, recurrent STIs, and unwanted pregnancies. All right, so now let's apply what we learned so far in identification. I'm just going to play two clips from the pit, and you guys can answer in the chat um, what you guys notice.
Hi, I'm Dr. McKay, Piper, Laura. And you guys are. She's my boss. Ooh, can I work?
I'm an accountant and she's my assistant.
Cool. Piper, are you okay with your boss being here while we talk?
Yeah, I'm good.
Are you sure? I'm gonna be asking you some pretty personal questions.
She doesn't mind. We have no secrets.
Okay. So burning with urination. When did that start?
About 2 days ago.
Why don't we let Piper answer the questions?
I'm sorry. It's just we've been waiting so long.
About 2 days ago. Any blood in the urine?
I don't think so. No, she would have definitely noticed that.
I'm gonna get you a gown and I'll be right back. Okay. Okay.
All right, so in this interaction, what do you guys notice that seems suspicious? You could answer in the chat. Yep, answering for her, boss not letting her talk. We don't have any secrets. Yeah, so the main part, the main red flag in this video is the patient's boss keeps speaking for the patient. The boss might even appear controlling in this situation. All right. Yeah, right. Katie brings up a good point. Like, why would you feel comfortable with your boss being there for personal questions? All right, and then this other clip.
Good. Good. You from Pittsburgh?
2 hours north, like Mill Village.
Okay. You have any family you want to call?
I don't have a phone. She can use mine if she needs to.
Okay. Lay down. I've never heard of her village.
Yeah, nobody else. Population 400.
Half that small.
Tell me about it. After high school, I had to get out of there.
Well, you're lucky you found a job. Any pain around here?
Mm-hmm. A little.
Okay. Sit up for me. You gave us a urine specimen?
Hours ago in the waiting room.
Okay. Well, I'll find the results and then you might need a pelvic exam.
Is that really necessary?
It could be. If there's no bladder infection, it's important to check.
Okay.
And if we do a pelvic, Laura will have you step outside for a minute.
I prefer to stay with her. First support.
Piper, do you want some privacy?
No, it's cool. She can stay.
Okay.
Yeah, what do you guys notice here that raises red flags? Yeah, good point. No phone. Boss won't leave her alone, even for like a pelvic exam. Yeah. Ola's saying like, yeah, why does my boss need to see a pelvic exam? Yeah, so some red flags are one, the patient's not from here, not being familiar with the area. Okay. She was from like a small town and now she's in Pitt. Um, she doesn't have a phone. Like everyone has a phone these days, especially an assistant. She was introduced as an assistant to an accountant. So like, how does an assistant not have a phone? Okay, that's another red flag. Um, if you notice with her micro like body language, she appears at least like maybe anxious whenever her boss speaks. And again, the overbearing, controlling boss answering for her. Um, who doesn't even want to leave, even for sensitive exams such as a pelvic exam. And if you notice, like the patient frequently looks at her boss or her boss for approval when answering questions, like, yeah, she could stay. All right. Good job, guys. All right. So now that you have a suspicion that your patient may be a victim of human trafficking, the next step is to establish a safe space. So first thing you want to do is go to the charge, label the patient as ESI2, okay? Type suspected HT in the comments box. Um, and move your patient to a private room, inform the charge nurse, and call ED social work at 4628. Okay. It's also important to note that even patients presenting with simple complaints like HIV testing by default assigned like ESI 4 or 5 and placed in fast track should be upgraded once they're identified or like has suspicion of being trafficked. Just like how you would do with patients in police custody. They don't go to fast track, they go to the main. Um, Then you want to interview the patients alone. Okay. Try to interview them alone as best as you can. Okay. If there's some resistance, you can use strategies such as saying, oh, that you're going to perform diagnostic tests in another area, or maybe it's hospital policy to interview the patient alone. You can also try to get help from other parts of the emergency department, like, for example, registration. You can ask them to ask the potential controlling family member or friend to step out of the room to assist with paperwork, demographic info, scheduling preferences for appointments. Or if that doesn't work, you can say, like, even for pediatric patients who are 13 and up, you can say, like, oh, it's um, New York State law that 13 and up are entitled to their own privacy. Okay. But if all of these uh, techniques don't work, and there's a lot of resistance, then okay, for adults, you can consider whether the patient, you yourself are in immediate danger. If that's the case, you can get hospital security involved. But otherwise, if um, otherwise, you also need to take a step back and consider whether you're doing more harm than good by forcefully separating the potential victim from their trafficker. This is different when it comes to minors because um, when it comes to minors, then you want to be more cautious, protect the child. So you want to get hospital security to separate the child and the guardian or whoever's accompanying them if there's a lot of resistance. Okay. Next is to interview the patient with a trauma-informed approach. Okay, so if you're able to interview your patient alone, use the first moments alone to inform them that you're available to help if they need, and that the ED is a safe space for them, and that they do not need to answer any or all questions. Remind them that everything they tell you is confidential, but you're still mandated to report like non-incidental injuries, such as injuries including firearms and sharp objects, severe burns, if they have any suicidal or homicidal intent, and if you find signs of abuse. You also need to consider like the patient's literacy level to ensure that information is like conveyed in understandable ways. If the patient needs an interpreter, you can get an interpreter, but also keep in mind should probably allow the patient the power to choose an interpreter that they're comfortable speaking with. Sometimes they come from a small community and maybe they're worried that the interpreter might know them or know people in their community. So if they don't feel comfortable speaking to a specific interpreter, you can always try to get a new one. Okay, and also keep in mind to minimize re-traumatization of the patient during interview by only asking questions necessary to determine the next steps with the patient. So this not only applies to trafficking, but also to like SART and DV. Okay, and then you can ask them if they're hungry or if they feel safe. Just some good questions to ask to establish a safe space. And then next step is you should ask some screening questions, or sometimes use screening tools to further screen to see if they're victims of human trafficking. So for adults, some screening questions you may ask is like, have you ever been forced to work to do work you didn't want to? All right. Have you ever had sex for things of value, such as money, housing, food, gifts, or favors? Has anyone ever taken your identification documents, such as like driver's license and passport, and why? Is anyone keeping you from seeing your families, friends, or tracking your movement? Has anyone lied to you about the type of work you'd be doing? And were you ever threatened with deportation or jail if you tried to leave your situation? So if they answer yes to any of these like example screening questions, uh, it would be considered like screening positive for trafficking. So you should definitely get social work involved, maybe start, let the institutional like trafficking coordinator know, and just be on more alert. You want to investigate this further. Um, Again, these are screening questions, so it's sensitive, but it's not specific. So for some of these questions, like has anyone taken your identification documents? It can also apply to situations where there's like domestic violence or abusive relationships. So this is why you want to investigate it a little further. But there's this like specific child sex trafficking screening tool where if two of these questions are answered with a yes, then this is also considered a positive screen. Such as, is there a history of drug or alcohol use? Has the youth ever run away from home? Has the youth ever been involved with law enforcement? Has the youth ever had a broken bone with traumatic loss of consciousness or sustained a significant wound? Has the youth ever had a STI? And does the youth have a history of sexual activity with more than 5 partners? So if any of these screens are positive, again, if you haven't contacted social work yet, you should call them, update them on the positive screens. You can call our institutional trafficking coordinator, um, NP Alice Blair. Her phone number is like 347-408-5568. She asked me to share it with everyone. And you can even consider calling the National Human Trafficking Hotline at 888-373-7888 for guidance. It's like a 24-hour line. And of course, if a patient is a minor, you could also consider getting ACS involved, but it's a tricky situation if the minor is not being trafficked by their parent or legal guardian, because if they're not, then ACS might not necessarily be required. But if you suspect that the patient's parent or legal guardian is trafficking them, then you have to involve ACS, right? Third step, examine and treat. So remember to examine and treat the patients for their presenting medical problems. If the patient's unstable, you got to stabilize them first. If they're there for like DKA um, or just like hypertensive emergency and so on, you have to treat that first, stabilize them, and then uh, and then proceed. So ED evaluations of victims include addressing acute medical issues, evaluation of possible and treated chronic medical problems, documentation of acute and remote injuries, treating and testing for STIs, and consideration for like SART activation and evidence collection if necessary. So when you examine the patient, always get permission at each stage, okay? Because trafficking victims have like every aspect of their lives controlled by the traffickers, so you can empower them in their exchange by asking for their permission with each exam. Also, very important is when you're documenting entries, um, do not be too specific about stuff like chronicity and measurements, because these exams should really be done by a medical forensic specialist. And if you are too specific with your documentation, it may be at risk of contradicting future documentation from these specialists, and it might hurt the patient in the long run in terms of like the law. And you can also ask the patient if they would like evidence collection, like voluntarily. And in that case, you would have a low threshold to call the SART team. Even if it doesn't meet like the SART pathway, the SART team also specializes in evidence collection. So you can consider calling them for that. And whenever we write a note, there's this button on the upper right corner of the note section. It's like a hide note button. Okay, you can consider clicking that and hiding the chart from the patient, because in case the trafficker has access to the EMR and like reads their notes, you can hide the actual like whole note from the patient, to protect them from that. Okay. And as always, in all cases of sex trafficking, you offer the patients the same resources as per the SART protocol, such as like HIV, PEP, STI treatment, um, lab testing, Plan B if applicable, and follow-up clinic appointments. Fourth step is to provide resources. So after you treat the patient, you should assess whether the patient's currently ready to leave their situation. You got to keep in mind that traffickers have control over many aspects of a victim's life, and that the victim is likely not going to be prepared to leave their situation during their first visit to the ED. But it's important to establish that relationship with them, and have them know that the ED is a safe space for them. Okay, so it's important to respect the decisions of the patient and know that each patient is in their best position to determine their own level of safety. And it's also important to provide patient-centered care, um, encourage them to come back when they're ready, and assure them that someone will be there to assist them when they come back. If that's true, like don't make any false promises, but try to maybe document or like flag the note saying that you suspect that they're a human trafficking victim. You can also provide them with information for the National Human Trafficking Hotline number. So that is the number on the screen. And there's also like a texting hotline from Polaris at the bottom of that blue box. You can text Be Free to 23373. And some ways to hand them this information is to like put on a sanitary napkin, on a slip of paper, maybe an RX pad with an order on it, if you feel it's safe to do so. Something cool from the pit is they had this pen that if you open it up, they actually had the number where the ink is supposed to be. So I thought that was pretty cool, like pretty discreet. And again, try to obtain as much contact information as you can, such as the patient's like emergency phone numbers, maybe emails, maybe like social media handles, if they don't readily have access to their phone. Okay. And finally, in the rare event when a patient states that they're ready to leave their situation, first you should perform a assessment of potential danger. Like, is the trafficker nearby? Will they be violent? Okay, so contact hospital police for safety, place the patient in a secure space. Um, Next is to involve social work and your institutional trafficking coordinator. And if at any point you need help, you can also call the new National Human Trafficking Hotline. So at KCHC, we would just reach out to social work and Miss Blair. At Downstate, you'll reach out to social work to assist in the process. But if you're working in an institution that doesn't have a SART team or 24-hour coverage of social work, you can always call this hotline. And if the patient's okay with it, you may contact like local or national law enforcement on behalf of them. Like the FBI has a specific branch for human trafficking. Homeland Security also has a human specific branch for human trafficking. It's not necessarily ICE, like they have their own branch. And finally, to develop a safety plan for them, like maybe admit them for safety and just coordinate with all of these resources to see what the next best step is. So key take-home points. First point is anyone can be a victim of trafficking. All right. Be aware of the red flags that may signal a potential human trafficking situation. Focus on patient-centered care and trauma-informed assessments. Remember that rescuing a patient is a rare situation, and pressuring a patient to leave their situation before they're ready may do more harm than good. Provide them with human trafficking resources so that they can start working on their safety and escape plan. And remember, you're not alone in helping your patient. Enlist the help of ED social work, hospital police, trafficking coordinator, medical forensic team if you have it in your hospital, ACS if this is a minor, National Human Trafficking Hotline, and um, many other resources. And I've been working on this for a while. It's still in drafting. It's still currently in the process of being compared and contrasted to the Kings County centralized protocol. Um, so I would like to share like my draft of like a potential human trafficking pathway that you guys can access on this Google Drive, in case you have any questions about uh, what to do for a patient that you suspect of human trafficking, and it includes many of the components that we addressed throughout this presentation. Okay. Here's some resources, some phone numbers for like the Brooklyn DA or FBI, Homeland Security, Department of Labor, Wage and Hour Division for like labor trafficking, Child Protective Unit, Safe Horizons Hotline, so forth. And our forensic department also has resources if you scan this QR code. And I just want to finally put it out there that here's like a good resource that you can also give to patients, Family Justice Center locations. They have people that can help the patient with planning for safety, applying for public benefits, shelter housing, and other support services, mental health counseling, on-job training programs, helping with resume writing and interview skills. They have referrals to education programs, including workshops with budgeting, credit repair, ESL classes. They have people who can provide legal help for orders of protection, custody, visitation, child support, divorce, housing, and immigration. And they also have connections with like law enforcement that can help out if they need, and the DA's office. Okay. And finally, I thought it was like pretty cool. They also have like childcare for children age 3 and up, while you get services at the Family Justice Center. And here's another resource, a public resource that you can use, like Safe Horizon, which provides similar resources to the public Family Justice Center. All right, here are my references. And finally, I just want to thank everyone for this incredible journey through residency. It's been tough 4 years, but I wouldn't have been able to do it without like the guidance of all the attendings, my seniors who are now like awesome attendings, my co-residents, and everyone, including the first years. Everyone pushes me to work really hard every shift. I learn from every one of you guys. You ask stimulating questions. I like teaching, and uh, residency is going to be tough, but I feel like we train at one of the best programs in the country. And if I were to do it again, I would. All right. All right. Thank you.